Today's a pretty exciting session, I think, exploring a disease process that has basically been relegated to registry studies until pretty recently, and with a pretty significant role emerging for point of care ultrasound for diagnosing acute aortic syndrome. So the structure today is going to be we're going to have the first half hour focused on a discussion of the recent SPEED paper with Dr. Ryan Gibbons. And then the second half hour, we're going to break out into some small groups, and I'll post the discussion guide just because I think the second paper is pretty dense. And so having people follow along would hopefully be helpful. And then at the end, at 3 Eastern or noon Pacific, we will kind of stick around and talk about any methods considerations that people have in recent papers, or if people want to dissect out methods a little bit more carefully in some of these aorta studies. I think it could be a fun time to bond and talk about challenges in research. So the way we kind of structure this is we'll ask you to mute yourself, turn your camera on, have your screen name kind of reflect who you are, your name, your position, and your location. And we'll take it away. So we have Dr. Ryan Gibbons here. He's not a newbie to PTL. He presented his study on medium joint arthrocentesis not too long ago. He's an associate professor at the Lewis Katz School of Medicine at Temple University, assistant dean of faculty development, director of ultrasound and undergraduate medical education, fellowship director, and producer of the finest studies in the recent years, I think. I really like the arthrocentesis one is one that I kind of keep pushing to people quite a bit. So this might be another one that's going to change how I teach ultrasound to people. We're going to talk about the recent SPEED protocol study. And what I kind of want to focus on is how this study came to be and got executed. I think I know that you've talked a little bit with other folks like Skeptics Guide about this study. And I think for us, what's the most interesting is like, how did you do a study over 10 years on a disease process that almost doesn't exist, and how you kept this going over the years? So I'm gonna stop sharing my screen if I can figure out technology. There we go. And yeah, take it away. Tell us about how you made this happen, because I
All
still
right.
don't quite
Well, I
understand it.
appreciate the very flattering introduction. I do have to correct one thing. I have to give a shout out to Mark McGee, who actually just took over as our fellowship director. So I
Ah,
stepped down because I took a new role in the med school, and Mark has taken over. So expect really good things from him. So we're excited to have him. He's been serving as assistant program director for a while and then has taken the reins. So I wanted to just correct that. So yeah, I wish I could take credit for this study. I mean, I think I can take credit for continuing it and whatnot, but Tom Costantino, who is the senior author, and who's our, he used to be our program director and is our division chief. He's the one that really came up with this idea. This was I want to say this was a year or two before I even started residency. Is he came up with a protocol. This is something that he wanted to do for a long time, and I kind of took the reins as I got more and more into residency, ultrasound, and things like that. So I have to give Tom really the majority of the credit to get this going and to keep it going because obviously to get to the numbers that we need I mean 10 years, I mean it was technically over 10 years that it took us to get there to actually have positive studies. So yeah, a big shout out to him. I think the biggest advantage we had is between Tom and our chair. Our chair basically mandates that. I mean, since he's been there long before me. I mean, he got there like late '90s, early 2000. I mean, mandated everyone is credentialed in point of care and really push for this to happen. And the way Tom has set up our division and our department, I mean, ultrasound is second nature. We have double digit machines in our departments, and it's just kind of a routine thing. And I think once he kind of established this protocol, it really became second nature that like if you're thinking dissection, your first step should be ultrasound. So like even when I started as a resident, I was like, oh yeah, of course I do a parasternal long and I do a full aorta sweep. And these are the things I'm looking for. So it was really kind of second nature. And that was all because of the support we had from the top down. And that's the only way we would have gotten the numbers that we did and the involvement that we did over a 10-year period across our three campuses, because it was just second nature. Realizing that this is, does not, mirror what happens at a lot of other, especially community sites. But that's honestly, that's really our culture is the way we made it happen. And I think the way we make a lot of our ultrasound studies happen is just it's second nature now. Like I wouldn't know how else to practice at this point, and I think I can say the same for our residents as well.
Yeah, that makes a lot of sense. One of the questions I had is kind of throughout the course of the study, it's 10 years. That's a lot of residents, clearly a lot of attendings. Is there is there a structure that you've developed to teaching this exam? And was there any evolution in kind of how you taught this exam? Because it is nominally it's a cardiac exam, but I know that, when we teach the cardiac exam, that aorta piece kind of falls off, and I feel like it's a separate teaching basically. Um, have you noticed kind of like pearls and pitfalls in QA that you've come up with where the views were good or not good, and kind of training people to really train their eyeballs on the aorta and not just on the heart in those cases?
Right. Yeah, I mean, I think, we taught them separately. Obviously, we teach cardiac as everybody else teaches it, the aorta as everybody else teaches it. It was just this idea of if dissection is on the differential, which it can be on a lot, and that's why we had so many,
Yeah.
such an enlarged enrollment with a very small actual pathology present. Yeah, I mean, honestly, we taught cardiac and aorta like everybody else does, and then just again got in the mindset of continually pushing for this, parasternal long sweep of the aorta as well, the abdominal aorta as the protocol. We have it listed in our electronic medical record as a specific study, so like it's already kind of built into when you go in. And it's something we push our interns on as far as when they're going through their rotations. QA, once we, see something missing as far as part of the protocol or something like that, we're aggressive as far as correcting that. Um, but yeah, I wish I had a better answer. I mean, Tom might be able to answer it better than I would because it was just so ingrained into how we practice that it was just like this is what we do and this is why we do it. And I think the advantage also was Tom made it that it was going to be much more sensitive to begin with. I mean, you look at the outflow track of 35 millimeters,
Yeah.
that's super sensitive. I mean, most people are going to have that just at their baseline. So keeping that simple as far as looking for an effusion, and then really just focusing on a flap in the abdominal aorta to kind of simplify things, because occasionally we'll see it in the outflow tract, but that's a tough to visualize. We didn't bother with a suprasternal or descending aorta because maybe you see it, maybe you don't. We really just focused on, do you have a wide outflow tract? Is there an effusion? And is there a flap? And I think simplifying it and just kind of beating the drum over and over again is the way we got it accomplished. And then it certainly helps as our residents graduate. We all drink the Kool-Aid at Temple. We stick around for quite some time. So it's interesting. A lot of our mid-level attendings now all were prior residents. So it's just kind of like it's this cycle that just is self-perpetuating.
Yeah, it's amazing. I know we kind of jumped into this just assuming that everyone's familiar with the study because it's made some sound waves over the last few months. But for those who are kind of cycling into the room, we're talking about the SPEED protocol with Dr. Gibbons. which was just published in Annals of Emergency Medicine in, I think it was March or February, right?
Yeah.
Um, and it's entitled The Sonographic Protocol for the Emergent Evaluation of Aortic Dissections, or the SPEED protocol, which is an awesome name, a multi-center prospective observational study. And what it is a look at practicing emergency clinicians, and in fact, residents, looking at patients with suspicion for aortic dissection, ultimately looking at over 1,300 patients and diagnosing, I think it was 44 aortic dissections, kind of evenly split between type A and type B dissections, and identifying a protocol sensitivity of 93% and a specificity of almost 91%, but with some confidence intervals that reflect how rare this diagnosis is. Is there any other takeaways that you think we should take from this study, like how to apply it clinically?
I mean, first, obviously, implement it. It's not a perfect study. It's got a very small n. So even if your protocol is negative and you still have a high suspicion, I mean, this is a can't miss diagnosis. So it's more of at this stage of the game, a rule in rather than rule out. I think depending how comfortable you are, I definitely will at times use it to rule out things if my, suspicion is pretty low. But I think the safest way to use it is as a rule in to expedite care. And the biggest takeaway also was type A, which are the much more concerning ones that really need to be diagnosed immediately, treated immediately. I mean, that is a way to expedite that. The type Bs, which we did miss because some of them are pretty small. A lot of them are infrarenal, which can be difficult to see. And I mean, you have time for them. So I think, it's a rule in, focus on your type A to expedite the diagnosis. But, any doubt, even with a normal speed protocol, which I will take credit. I did come up with the name. It took some time, but Tom came up with the actual protocol. So I'll take credit for the name though. I was pretty
That's
proud of it.
a cardiology level acronym right there. That's
Yeah,
what
it
that
took
is.
me a while because I was like, it's got to be fast, like the fast exam. Yeah, that was my labor of love. Tom did all the other heavy lifting. So, but yeah, no, it's a rule in, and focus on your type A's. And if you're still suspicious of a dissection and the protocol is normal, go on to your CTA, get your surgeons involved sooner rather than later. Start treating that blood pressure sooner rather than later. So. Um, yeah, I think they're the big takeaways, and certainly, we're hopeful people take this and run with it for bigger studies and more robust data to show the utility of point of care with aortic pathology.
Yeah, I don't know that we'll see a bigger study anytime soon. You've said keep it simple at least 5 times so far. And I think that's something that shines through in this manuscript is it's very simple. Like it's just this is what we did, this is what we found. There's no big subgroup analyses. There's no like trying to dissect it out. It's a very, very clean message. And I think I know that when I'm writing a paper, I am just like, I got so much data. I want to show you all of it. Can you talk a little bit about how you put this manuscript together? Because I think, especially as we dive into the other paper today, I think, that one is very dense. That has a lot of stuff. It has more supplementals than non-supplementals, which is great. I mean, I enjoy kind of that nerdiness too, but this is a very clean message. Can you talk a little bit about how this paper got structured, the writing process of it, and how you kind of came up with how to put this together? Because I think, especially for many of our junior learners and myself as well, that's something that I think this paper can just be given as an example of like focus on your message, kind of a writing clinic almost.
Yeah, and it's funny. Like I say, I guess I do say it a lot because I even on shift, I'm like, keep things simple. Like, this is not like rocket science here. We're trying to answer yes, no questions. We're looking for the emergencies. We might not always have the answers. So, yeah, I mean, EM is busy. We have a lot of unknowns. They're critical people. So I think the more you can simplify something, you know, the easier it is to adopt. And I think from the get-go, that was Tom's idea as far as like, hey, these are, you know, what we typically look for, or the potential like secondary findings of dissections. And if we can put this together into like a complete protocol that is, again, still simple. I mean, again, what you get is a dilated root, you get a fusion plus minus, and then you get a flap. Like these are the things, you know, keep it simple. We didn't get into like ulcerations or anything like that because, I mean, how clinically relevant that is, and that's just, you know, not the true emergency like a dissection. So, and really, it was a look at the diagnostic characteristics of an imaging modality, a protocol. So, like, we weren't looking to report anything else. We really wanted to see, you know, is this going to be a useful imaging modality to at the very least expedite a diagnosis that's rare, but critical. So I think, you know, the easier we make things, the much more likely they'll be able to be adopted. And I think that was, again, the same thing, you know, with our residents and our faculty. You know, if we made it too complicated, like, oh, remember look at the descending aorta, remember look at the suprasternal view and all this other, and you're like, there's just too much to think about in a time sensitive, potentially time sensitive scenario. So yeah, I think simple is the way to get it, way to get people to do it. And that's kind of what we wanted to report. You know, we wanted to see what we were looking as far as type A and type B and overall between the two. So there wasn't much else, I think. You know, we really wanted to, at this stage of the game, we just wanted to show or not show, could point of care help answer this question.
Yeah, I love that. And I know I've been kind of like singing the praises of this study quite a bit. I think I've learned a lot, both kind of how to do research and how to write things up, just looking at this paper. I think, you know, it'd be remiss not to talk about some of the limitations, some of which you've kind of mentioned. You know, on the one hand, this is an exam that is not substantially different from what we teach already. It has, you know, it really, to my mind, what it is telling people when they're doing the cardiac exam to put their eyeballs on the aorta as well, right? And so that really kind of like, to me, makes this feel a lot more generalizable than, you know, regurgitant jets and suprasternal views. But at the same time, like, I do enjoy teaching the descending aorta view because it's like such a cool view when you get it in view. Did you, when you did your QA, did you find things on the descending aorta view, or were you looking for that? Were you seeing additional views and, like, at least anecdotally thinking about whether they're helping or not?
Only after the fact, really, because we didn't advocate at all. We said no to the, like, at least the protocol. I mean, if somebody did a suprasternal, fine, but I honestly, I don't remember any. I mean, I don't remember any suprasternal one that I would like. So it would, again, it wasn't, because like it's funny. I talked to some of my residents or attendings, and like, you know, even when we teach cardiac, we have the 4 standard views, but a lot of times, like when you're in a busy shift, you only need 1, maybe 2 views, and you got your answers. So again, we wanted to keep this as simple as possible. So we didn't even mention suprasternal or descending to anyone. I know for sure, as far as descending, we had never, we didn't see an actual dissection on any of them. And to the best of my memory, I don't think there was a suprasternal included anywhere. Now, since then, it's funny. We do, like the other day, somebody had a dissection and they're like, I got a cool suprasternal view, but I was like, was the protocol positive though? Like otherwise without that, like, but yeah, I think again, it's simplicity to get it out there. You know, because again, we're in a very resource limited, time sensitive, you know, and that's kind of how the paper was designed too. Like,
Yeah.
you know, a very simple approach, to encourage its use.
Yeah. And I think the other piece here is that really thinking about it from a specificity standpoint allows you to generalize it more to really anyone who's trained in cardiac ultrasound, which should be every emergency medicine residency graduate at this point, because just because you didn't catch it doesn't mean you shouldn't do it. And if you catch it, then we know from this work and Joe's work and a few others that your time to diagnosis really matters and you get to reduce it.
And the one thing you mentioned, I do like it, we're doing the traditional views. It's not like we added something that was like, hey, did you ever think about this? No, I mean, everybody's been doing this already. It's just like, hey, take a little bit closer of a look of your outflow track. Instead of just a AAA when you're looking for your abdominal aorta, remember that dissection there. And then the same thing, if there's an effusion, why is there an effusion? Like, it's just things, to kind of put the pieces together and maybe focus a little bit more on different aspects of your just traditional parasternal long view.
Yeah. What do you think is next? We have this ACEP clinical policy that says, like, don't rely on decision rules. We don't rely on D-dimer, which seems to mean like scan everybody. We have this paper and we have the other paper that we'll discuss today, kind of showing some additive value of ultrasound and decision rules and dimers. Do you think that, we're kind of headed to a place where we could start rewriting that clinical policy and giving ourselves some leeway to avoid irradiating everyone, or are you not ready to make that conclusion from this data and other? I know it's putting you on the spot.
Yeah, no, yeah, of course. They'll listen to Ryan giving some rando from Philadelphia to change. Now, I mean, again, certainly I think, we are biased in our interest and in our skill set with point of care. And I think, I'm much more comfortable than the average, EM physician. But yeah, I mean, you really look at our study. I mean, we had 44 dissections. I mean, that's not enough to, I wish it was, but it's not enough to, again, like I said, if you don't have an effusion and your outflow track's narrow and you don't have a flap, but you're still worried, you got to get that scan, especially the type A ones. Like, yeah, maybe down the road, but yeah, I don't think we're there yet. Again, if my suspicion's still high, I'm going to scan them either way. So
that's fair. Do you have any, I know this paper is very clean, but do you have any secondary analyses that you're thinking about from this data set?
Do you have any ideas? Not like I didn't at this point. I was just happy to finally get it. I mean, you guys get it. It's tough to do research, like especially ultrasound. I mean, it's not like everybody's like geeking out like us to do point of care in the ED and to get non-ultrasound people to buy into it, and it's tough to get funding. I mean, it's so yeah. I mean, right now I don't, but if you have an idea, I'm game to hear it. So
I mean, there are so many things that I was interested in, like just maybe it's a little bit retrospective, but applying an ADDRS score to these folks that you ultrasounded and seeing kind of where they land, right? Like, who do we really need to be worried about? And were there those zeros and ones? We'll talk about that score system next, but were there those zeros and ones who, this ultrasound exam kind of pushed them along in the right direction rather than premature closure? That was one of the thoughts I had.
Thing about ADDRS.
Say that again.
I was literally thinking the same thing about ADDRS and seeing if you could apply it there. I don't know how many times you have D-dimers on them, but that would be something that gets interesting.
Yeah, it's funny you should say that, because one of our residents, we do these like content expert program, it's called, and all different reasons, to just have a little bit extra training in different subsets of EM, and they have a project due at the end of their third year. One of them was D-dimer. Now, this was started well after our protocol and stuff, but yeah, I can't say. I mean, it's not even on my radar to do a dimer for a dissection. Like, I'm doing the ultrasound, and then whether that's plus or minus, I'm scanning. Especially for a type A, if I'm sitting around waiting for a dimer, and I don't know what any other place is like, but I could get a dimer, and then 3 days later, it finally comes back once the lab finds it again, and but it would be interesting to see if there was with the scoring system or, with dimers and stuff like that. Because certainly we do have a lot of data. So if I get motivated, or maybe one of our fellows gets motivated, we'll dive into it a little bit more.
Super cool. We have like 3 minutes before we jump to the next section. But if anyone has any questions, please feel free to either throw them in the chat. Oh, Andrew asked about surgeon opinions for the protocol. Were you able to get them on board?
Oh God, no. No. Are you kidding me? Like, I wish. No. And it's funny because one of our surgeons who's great, like she's a big proponent of ultrasound, but even like it just made me laugh because like even appendicitis, I'm like, can we do the appendix? Like, we can at least get them down, especially when we have a flap. If we have a flap and they can see it, because we upload our images right to our PAC system so they can see it. So in those regards, they are down there at the bedside much sooner. They're still, we're still stopping at CAT scan and maybe right up to the OR. So it has gotten them to the bedside before. Has it reduced CAT scans? No. Maybe one day, but not yet, and definitely not for type Bs, just because we don't, we have more time to, to deal with those. So. Maybe if we clocked how quickly our colleagues came down, that's probably reduced, but not the number of CAT scans, unfortunately.
But do you think the time to definitive diagnosis is reduced? It sounds like it would be if you actually catch it and
100%. Because usually the way we do it, like if we see it, or say I have an effusion or a wide outflow tract, and I'm like, he's got a pulse differential or whatever, like I'm like, we're heading to CAT scan immediately. Like I'm waving the creat, I'm calling CAT scan. So yeah, we didn't look specifically at time or anything like that. I wonder if I could pull that from all the data we have from the medical record. But yeah, I mean, anecdotally, I would say time to diagnosis, without a doubt. We just didn't look at that specifically, but anecdotally, without a doubt, like it is. Like the other day when we had one, like sadly the guy passed, but he came in. I mean, our resident had the diagnosis as soon as he hit the floor, and we were up at CAT scan, and he obviously coded, and just we couldn't get him back. But yeah, time to diagnosis anecdotally, and that'd be cool to look back to see if we did have the data, at least when we had the read or the scan ordered or something like that. But yeah.
Do you all have like what's it called, like a code aorta or aorta activation?
We don't. That's interesting. Yeah, I think because they're so rare, and I have to say, like our population, I mean, we have a fair amount of very poorly controlled hypertensives and and crack cocaine abuse, and we have a ton of dissections all the time. I mean, they get transferred out, or they have prior ones, or they got CAT scan before we get the ultrasound. So we certainly didn't capture everybody that presented, and even what we had was still kind of more than your average. But yeah, we don't. It's still nothing like on the lines of a a PERT team or something like that. But
we kind of instituted that fairly recently, but I think not everyone's aware of it. But it encompasses AAAs and dissections.
I mean, that's a great thought. I may bring that up with our leadership, because again, I think having multiple people on board and making things happen a lot quicker, because it really works well for the PERT team as far as getting to scans or interventional therapies and things like that.
Sounds great. Cool. So we will stop the recording.